Welcome to Window and Level. Here we break down complex radiology topics and adjust them for clarity. I am Bianca Guedes, your host, and today we're starting a deep dive into the imaging of premature babies from head to toe. Dr. Bianca Guedes is a pediatric radiologist at University Hospitals Cleveland Medical Center and assistant professor at Case Western. She named this episode series Born Too Soon. And today, in this first episode, we focus on imaging of the premature brain, bowel, and bones. Let's get started. Dr. Bianca Guedes, thank you for coming.
Thank you. My pleasure. Thank you for the invitation. It's an honor to be here with you and in this project that is amazing.
The honor is definitely mine. Before we jump in, is there any reason why this topic matters to you personally?
For me, prematurity is where imaging really changed life. When we look at these babies, we're not just seeing disease, we're seeing development that was interrupted. So when we think about the embryology and imaging, it helps us a lot to understand what happened before birth and what that means for the future.
That's powerful. So let's ground this in reality. How common is prematurity globally nowadays?
So prematurity is very common worldwide. We have about 13 million babies born prematurely every year, roughly 1 in 10 births. You see these patients everywhere, and imaging findings often will be a very good guide to big decisions about the management and the prognosis of these babies. So imaging in the premature population is very, very important.
So this isn't rare at all, and every resident is going to see it. 1 out of 10 babies.
Like 10%.
Yeah, this is very common, which is why the imaging matters. Now, let's talk brain. This is our first topic. When does the germinal matrix, the region of the brain that is most vulnerable, when does it become matured?
The brain is most vulnerable before 28 weeks because of the germinal matrix. So it's highly vascular and very fragile. By around 34 weeks, the germinal matrix will involute.
So, say a baby born at 26 weeks is still very vulnerable.
Yes, because we have a lot of germinal matrix yet. Usually the last area that still has germinal matrix is there until 28 weeks of age and is the caudothalamic groove. And actually, nowadays we have some very premature babies that are viable.
And how does that vulnerability actually show up clinically and on imaging? What do we see?
Clinically, these babies are prone to bleeding and ischemic injury as well. So on imaging, that shows up as germinal matrix hemorrhages, also intraventricular hemorrhages or IVH, and also white matter injury. I like to think that the brain is like a construction site that is still unfinished, and easy to damage. And it's very, very important for us to know about them and to look for it when we're doing the brain ultrasound.
I like that analogy of the construction site. Definitely, it's a big, big construction, which will matter a lot as a foundation for the whole body.
Yes, and very fragile, right?
So, brain hemorrhage is one of the manifestations. Let's talk about the grades of the intraventricular hemorrhage. How many grades are there, and what's the difference pathophysiologically?
We have the papilli classification, and we have 4 grades. So grade 1 is the bleeding limited to the germinal matrix, especially the caudothalamic groove, which is the most common area. Grade 2 will be extending into the ventricles, but without dilatation. 3 will cause ventricular enlargement, and usually we're going to have more than 50% of intraventricular bleeding. And grade 4, which is the most concerning one with the worst prognosis, it will involve injury of the brain surrounding the germinal matrix. And actually, it's not the hemorrhage per se in the parenchyma, but we have hemorrhagic infarct in that area.
So grade tells you immediately the severity of this pathology.
Exactly, yes.
How about the prognosis? Does it change?
Yes, grade 3 and grade 4 hemorrhages are the worst in prognosis. Usually these patients will be the ones that will have some poor outcomes, unfortunately. For the grade 4, for example, we're going to have malacia in that area. And the intraventricular large hemorrhages also frequently they are associated with hydrocephalus, post-hemorrhagic hydrocephalus, which is very hard to treat. with time, we start to see some very large areas of malacia or atrophia.
And how do we diagnose this? What do we see on ultrasound for each grade?
Okay, so ultrasound is the main screening and follow-up tool. Grade 1 will appear as echogenic material in the caudothalamic groove, but if the baby is super premature, less than 28 weeks, sometimes less than 25 weeks, it can go posterior to the caudothalamic groove. It's quite common, and we have this in the literature already showing, and it's very important for us to differentiate in extreme premature babies, differentiate these posterior germinal matrix hemorrhages of possible parenchymal hemorrhages, because sometimes they overlap. The grade 2 will fill part of the ventricle, right? But not entirely, or more than 50%. But the grade 3, yes, we're going to have more than 50% of the ventricles involved by the hemorrhages, and usually they are enlarged. Grade 4 will be echogenic parenchymal injury that may later become cystic, meaning encephalomalacia.
You also talk about periventricular leukomalacia. How is it different from hemorrhage?
Yeah. So PVL, or periventricular leukomalacia, is white matter injury related with hypoxia and inflammation. There are some other theories regarding infection, other possibilities, but the major association is with hypoxia and inflammation. And usually early on ultrasound, we're going to see increased echogenicity near the ventricles, usually bilateral and usually symmetric. Okay. In premature babies, we can have normal hyperechogenicity of the periventricular white matter.
And is there any trick how to differentiate this physiologic blush versus PVL?
The key difference from the physiologic blush will be that the normal blush fades within a week, and we won't see cysts in the area. And usually the blush is very mild, very small compared to the choroid plexus, which is a good tip. You always compare the echogenicity of the brain parenchyma with the choroid plexus. If it is higher than the choroid plexus, usually it's pathologic, okay? But the follow-up images will show just a normal brain parenchyma. When we have grade 1 PBL, it will stay like that in the second image after 7 days.
So follow-up is crucial.
Yes, it is.
And what is the clinical significance of PVL?
This is a very good question, because PVL is one of the strongest imaging predictors of long-term neurodevelopmental problems. Cystic PVL, especially, it is highly associated with cerebral palsy, unfortunately. So this is very important for us to early recognize, and follow up is so important.
Yeah, when we see these tiny babies, these micro changes, we have to realize that follow-up matters, and we need to give them information about what might happen down the line.
Yes, exactly. Sometimes you're going to be able to see the atrophia as well, and also injuries that are not obviously early, but with time, serial imaging will really matter.
And we pay attention to, you mentioned transformation to cyst, atrophy. Are there any other findings that will show us that changes are progressing?
Yes, one good example is the hydrocephalus. Usually when we have association with intraventricular blood products, and with time, we start to have some septations in the ventricular system, and it's very hard to treat. So this is one of the serial imaging most common findings associated with the other more classic findings, such as atrophic parenchyma.
I see. So we're not just looking for one thing. There are multiple findings that we need to track. You kind of track the story, how these first weeks of life of the baby are going.
Yes, exactly.
Well, let's shift gears now. Let's go into the bowels of a small baby. So, necrotizing enterocolitis, one of the most dramatic and dangerous, scary diseases affecting premature babies. Let's talk about that. What is necrotizing enterocolitis, and what babies get it?
Necrotizing enterocolitis, or NEC, as we know, is a serious inflammatory and ischemic disease of the bowel. So it mainly will affect very premature and very low birth weight infants. It's very important, the weight. When we have less than 1 kilo, it's the most concerning in terms of risk, and especially those with cardiac disease and very unstable perfusion.
And what are the stakes?
Yeah, so overall, the mortality is very high. it is around 20 to 40% in general. But if we have perforation, it's going to be even higher, more than 50% of mortality, especially when they need surgery.
So we got to catch it before it perforates.
Yes, exactly. We're going to have some stages. The highest stage will be perforation and pneumoperitoneum, and then they need to go to surgery.
Do we see it immediately on imaging, or does it develop with time?
The first stages can be totally normal by imaging. Usually, the clinical aspect is very important. Usually, the babies are very unstable and they start to have abdominal distension, like very general abdominal distension, nothing super specific. And remember, the babies are very small, very hard to do the physical examination. Sometimes we're going to have an x-ray, an abdominal x-ray with just paucity of bowel gas, but sometimes you're going to start to see some bowel distension with some abnormal gas patterns, like some areas of discrepancy of caliber, an area of persistent dilation of bowel loops in the same quadrant. So this is one of the early stages that we can see.
So initially, those changes are super subtle.
Yes, exactly. Early imaging can be very, very subtle.
Walk me through the progression. What do we see on X-ray as this necrotizing enterocolitis gets worse and it's more evident?
After some time, we're going to start to see the very specific findings that are pneumatosis intestinalis, which is air in the bowel wall, within the bowel wall. And it's very subtle, but very specific. When we see it, the chances are very high that we have necrotizing enterocolitis, especially when we have a NICU baby that is very low weight birth and also with instability, right? After the pneumatosis intestinalis, we're going to start to see the portal venous gas, which is branched areas of very tiny radiolucencies overlying the portal venous system, meaning the hepatic area on X-ray. And the very last stage, the most concerning one, will be obviously bowel perforation with pneumoperitoneum, which is meaning that we need surgical repair.
So when you see pneumatosis, this is your wake-up call. You're going to pick up the phone and tell them that this baby may perforate.
This is a critical finding. We need to connect directly with the NICU attending or the resident, let them know that we have a high suspicion for necrotizing enterocolitis, and usually the patient already has some clinical symptoms as well. There's another tool that we can do. We can do a lateral decubitus with the patient with the right side up, because then when we have this, we can confirm the pneumatosis. We can try to see better the hepatic area to search for the next step that would be the portal venous gas. And also we can try to exclude with more sensitivity the next step, which would be free air, right, in peritoneum. Because with the left side down and right side up, it's going to be easier for us to see the free air.
Yeah, and just to loop back, when we see that free air, it's perforation, the prognosis is poor.
Yes, exactly, unfortunately.
How does radiography versus other modalities help us? Are there any other things that we can use to diagnose NEC?
Yes, very good question. And I would say that the X-rays will be the first images because they are usually very frequent type of imaging that the NICU patients do. So they're doing usually follow-up exams for the chest, and then we also take a look in the abdomen because they have several lines and tubes. Usually it's going to be the first type of imaging, but I would say that ultrasound will be the most sensitive method for very early changes for NEC, meaning that ultrasound can detect NEC earlier than X-ray, and we know that from the literature. It shows bowel wall thickness, perfusion. We can see the perfusion. At the beginning, it's going to be high, and then with time, we're going to see ischemic changes, decreased bowel wall Doppler flow, right, like vascular flow. And then we start to see the pneumatosis as well. It's really, really sensitive for that because we can double check if it is for sure outside the lumen and in the bowel wall.
Correct me if I'm wrong. On ultrasound, we see the findings of NEC earlier, and we will start seeing increased bowel thickness, some decreased Doppler vascularity, And eventually that will progress to pneumatosis, which we see on X-ray.
Exactly. Yeah. The limitations with ultrasound are only because they're very examiner dependent. There are other very important findings that we're going to add with ultrasound. We're going to start to see complications that we can't see on X-ray, fluid collections, because we're going to be able to scan the areas in between bowel, and usually they're not well seen by X-ray, of course. We kind of start to see just free, simple fluid at the beginning, but as neck gets worse, we're going to start to see septations, debris, and fluid collections. And this is a highly predictive finding for very poor outcomes from the literature. This is just before the patients start to develop pneumatosis and portovenous gas. And then pneumoperitoneum if we don't treat.
I see. So this is another red flag that we see on ultrasound. I like that we can use multiple modalities to add the value as radiologists. Of course, it requires very fine skills with ultrasound to see changes in the bowel or collections, especially if the abdomen is distended with the gas, right?
Yes, that's true. Yeah. Think of ultrasound as seeing the bowel live, not just its gas pattern, It's not just a single moment of the evaluation of the bowel. By ultrasound, we can see it real time.
What are some other pathologies that we look for in the bowel we should be aware of to screen for?
The bowel gas pattern can look very similar when we have early changes of neck or other conditions such as spontaneous intestinal perforation or functional ileus, meaning that we have a very dilated bowel gas pattern. Usually it can be diffusely seen if it is just functional ileus, but sometimes we start to see some asymmetric pattern of the bowel. So X-ray is super important for this evaluation of differentials of the bowel pathologies in NICU patients.
But for the premature babies, we really got to make sure we don't miss that necrotizing and enterocolitis.
Exactly.
Ultrasound can hopefully help us find it earlier.
That's true. Totally true. Yeah. And you can go bedside. You can do that even late hours. So it's a very important tool for peds in general, but for the NICU patients, super, super important.
And last system I want to touch base on today is musculoskeletal, because the prematurity affects every single system in the body. Metabolic disease of prematurity. What is it?
When we have a very, very premature baby, we're going to start to have this type of metabolic bone disease because these premature babies will miss the third trimester, which is the most important moment for calcium and phosphorus metabolic changes. So this transfer won't occur.
What do we see on X-ray?
So on X-rays, we're going to see a very low bone density, so decreased bone density. And sometimes we can see increased long bone periosteal reaction. With time, these patients can start to develop some pathologic fractures that are more common in the ribs or sometimes long bones as well, but more common in the ribs.
How do we differentiate these findings from rickets?
Rickets is a little bit different because it's going to involve a defective mineralization, often related with vitamin D. We're going to see metaphyseal cupping and fraying and widening of the metaphysis. And it's different of the more generalized osteopenia of metabolic bone disease of the prematurity. But sometimes they are associated. We're going to have both.
It's a vitamin D deficiency, so prevention through nutrition would matter for those babies.
Exactly, yeah. Bone disease in prematurity is very common, but it can be preventable, as you said, because imaging will help us to identify it before the fractures start to appear. So they can do the treatment while the patient is doing the other treatments that they need because of prematurity.
So far, we've covered brain, bowel, and bones. Before we jump into lungs, there's a big picture question for you. What connects all these complications pathophysiologically? Is there any underlying thing that unites all of them?
In the brain, we're going to have, as we discussed, fragile vessels and bleed. And when we talk about the premature lungs, we also have the immature vasculature that leads to edema and chronic disease. In the bowel, we're going to have poor perfusion as well, increasing the neck risk, as we just discussed. And The same vulnerability will happen in every single different organ, such as the MSK area as well.
So it's all connected by fragile vessels.
Yes, exactly.
Which means that if I recognize one problem, say for example, there's prematurity of the lungs, we should look deeply into the brain changes or be aware of necrotizing enterocolitis in these babies.
Yes, it's always a sequence that we need to check head to toe. That's why usually we need to think in these patients as complete. We can do ultrasound head to toe, except for the bones. We're going to be able to scan at bedside and have very high sensibility and specificity by ultrasound to diagnose very important conditions and help the providers to change the management and let them know about how severe is the pathology, and we can even predict the bad outcomes that sometimes are associated with our imaging findings.
So the imaging that we're reading is given the clinicians and parents idea of how the baby is going to do in the future.
Exactly.
This is why this matters so much, the work that we do for the patient's family and for the doctor. This is part 1 of Born Too Soon. Now you have the framework for diagnosis of germinal matrix hemorrhage, able to identify necrotizing enterocolitis early, and understand metabolic bone disease. Looking forward to your comments about this first episode. Follow up next week when we talk about lungs and air leaks. Subscribe so you don't miss part 2. This is Window and Level. Thanks for listening.